we have to make it easier for people to know if they are with a safe provider. And just the nature of how this works, being with a CPM or a lay midwife or a direct entry midwife is going to be a little bit less reliably safe. I love midwives. Do not get me wrong. I work with midwives here in New Zealand every day. I worked with midwives back in the States. I just think that the way that we have such little oversight and standardization of training for various types of midwives is problematic. So you can see here, certified nurse midwife, certified professional midwife, direct entry midwife, and lay midwife. These are all allowed to call themselves a midwife in the United States. Most midwives in the US are certified nurse midwives and certified midwives, and those would fall into a category that do have oversight and training. So certified nurse midwife and certified midwife, CNM and CM. These are going to be like top level of midwife in the US. This is what in other countries would generally be considered a midwife as well. The other categories we go over would not be categories of midwives that are largely recognized in other places in the world. I mean, there may be some places, but not generally. You have a graduate degree required to have certification. For nurses, they go to nursing school first, and then they go on to get their CNM. For certified midwives, is a graduate degree, but it's not a nursing degree. Does that make sense? So they both have high-level education, but one of them is a nurse and the other is not. They have a certifying organization, the American Midwifery Certification Board. Nurse midwives are licensed in all 50 states. Wow, I didn't know only 8 states licensed certified midwives. Primarily attend births in hospitals. Now, the reason for this is because most hospitals do not allow people to attend home or birth center births and also hospital births. This is different from other places in the US, and this is one reason that home birth in the US is a bit less safe than in other countries. It's because whether outwardly visible or not, there is an inherent incentive for people who are delivering babies at home or in birth centers to keep patients there as long as possible. I'm not implying there's a monetary incentive from this standpoint. It's just a subconscious desire for the patient's best interest to be able to stay with them. And if you transfer to a hospital where you don't have privileges, you can't continue to birth. The juxtaposition of that here in New Zealand where I work, the midwives, if they are planning a home birth and then they end up needing to come to the hospital, the midwife comes with them and is still able to attend and facilitate the birth in the hospital, even if they require intervention from obstetrics. Like, I don't deliver babies here unless I'm doing like an operative delivery, forceps, or a vacuum, or a C-section, because the midwives come with them and they get to stay. Whereas back home, the good midwives would come as essentially visitors or come and help attend the birth if they had to transfer a patient to a hospital. But I would have midwives occasionally just drop people off at the door, no handover. I don't get any information on like what's going on, what's been going on. It's all secondhand through the patient, which is not the best way to transfer care. So this is a problem that would be needed to be fixed on the hospital side. Midwives who are certified nurse midwives or certified midwives who are boarded by the American Midwifery Certification Board should be able to come with their patients and deliver the baby in the hospital. There's a lot of reasons that hospitals don't do that, and a lot of it has to do with liability, insurance applicability. Getting privileges is complex, and that's just not what they've traditionally done, but that has to change. It needs to change. However, once you start adding in the fact that there are certified professional midwives only require the equivalent of a high school diploma with some additional certification from North American Registry of Midwives, you have a bit of variation in these people's skill levels that's more broad than additional CM and CNM programs. There can be variation in all skill levels of all kinds of healthcare providers, but a lot of certified professional midwives will be capable of providing low-risk pregnancy care, but there's a lot of variation in what the requirements are for them to complete that program. And so by saying that I would not personally use a CPM and I would not recommend people use a CPM, I'm not saying everybody who is a CPM is dangerous or unqualified. I'm not saying that at all. I just think the general public doesn't have a way of knowing that information, and we have to make it easier for people to know if they are with a safe provider. And just the nature of how this works, being with a CPM or a lay midwife or a direct entry midwife is going to be a little bit less reliably safe. I think the clinical requirements for midwifery training are really interesting. And again, I really want to reiterate, I think that New Zealand's system of care, where every single person is cared for by a midwife, is superior to the United States. I am very, very, very in favor of midwife care. I think over-medicalization of birth is a problem. I think midwives should be primary caretakers for people who are pregnant, and obstetrics should be a consultation when needed. I just don't think that the setup that we have in the United States at the moment makes that very safe. So you're looking at certified nurse midwife, certified midwife, and certified professional midwife here. So graduate degree certification does not require an academic degree, but does have some competency and specifications on knowledge and skills. NARM requires that the clinical component of the educational process must be at least 2 years in duration and include a minimum of 55 births in 3 distinct categories. For reference, that is less than I did in my first 6 months of residency, and I was in residency for 4 years. I don't know if that's enough or not. I'm not saying it's definitely not. I'm just saying that's not very many, because 55 births may sound like a lot to people who don't attend births. There's so little congruency across all of these various people who can call themselves a midwife. And I don't think that the onus should be on the general public to decide if they think somebody has enough training or not. Being able to say, I'm a midwife, should mean that you have enough training anywhere you go to be a licensed birth attendant. There's no possible way that you attend that many births and get an understanding the breadth of things that can go wrong and how to manage them. No way. And I don't know what the requirement is, though, for certified nurse midwives either. So there's also a difference with the training in that I don't know about CPM or CNM or CM, but with us, in the 6 months that I first was in residency and delivered that many babies, I also was peripherally involved in hundreds more deliveries and daily discussions about 10 to 20 patients who were in labor or had had a baby, and talking about the various complications that they had and how you managed them. And I'm not saying that midwives should have the breadth of training that we have as obstetricians. That would be ridiculous. But I am saying that there is something to be said for the way that the training happens, whether you're in a big group environment where every day you're discussing 10 or 20 people who are pregnant and the complications that they're having and how to manage them. And in addition to that, you're attending births and doing prenatal care, versus just having these 55 births that happen over the course of 2 years or whatever, where those are the only 55 pregnancies that you've even peripherally been involved in. Does that make sense? So I might have delivered 200 babies in residency, but in addition to that, there were 1,000 pregnant people that I helped decide the course of management for their pregnancy and prenatal care, which is a huge learning opportunity as well. But that is less likely to happen in small midwifery programs. And again, I don't know that this is as easy as just saying, oh, you need X amount to be capable. I just don't think that all of these people should be able to call themselves midwives. I just think that it's misleading for the public. And my whole point in this is not that any of these people should be disallowed from doing whatever it is they're trained to do. I'm not one for gatekeeping. I just think that the lack of a consistent meaning for what level of training it is when you are called a midwife is concerning. And if it's confusing to me, it's definitely confusing to the general public who's trying to make decisions on who is equipped to safely care for their baby.